Thanks for inviting me to give this presentation today. I have no conflicts of interest to declare for the presentation. What we're going to cover today is to review a protocol that is intended to help clinicians remember to think about amoebic encephalitis when a patient, doesn't have to be a child, when a patient presents with signs of meningitis, and then to confirm that suspicion with early diagnosis. You heard from Dr. Liriano how early diagnosis really had an impact on the management of Sebastian. When I've reviewed the cases of all the United States PAM survivors who had a normal neurologic outcome, they were all diagnosed within 3 days of onset of symptoms. That may be a critical time period, we're not sure, but that is our goal. I'm not going to go much into PAM diagnosis because we heard a great presentation from Sheila Black about the laboratory diagnosis. And for someone who claims not to be a public speaker, she's an outstanding public speaker, don't you think? So, and this is her same video of the amoeba moving on the wet mount. So we'll just move on. We can also detect Naegleria fowleri in spinal fluid with polymerase chain reaction, PCR, which can actually detect the DNA of the organism in the CSF or a tissue specimen. Unfortunately, most laboratories do not have the capability of doing that, but that's the confirmatory test that can be done when our specimens are sent to the CDC parasitology lab. Amoeba can be detected in culture too, but this is not an efficient way of looking for it. You get a petri dish that is coated with E. coli, and the CSF that's placed on that dish, if it has amoeba, the amoeba will eat the E. coli, and as they travel across the plate, you can see the paths of the amoeba where they've eaten the bacteria. That can take over a week to get a positive result. I mention that in that detail because I last year had an opportunity to just visit a local hospital in Tampa, and I heard a discussion about a young boy who had been admitted with signs of meningitis. And he had already been there for 5 days at the point that I was visiting, and they were discussing the case. I was listening to the discussion. Someone had elicited a history that he had been in fresh water the week before, so the hospitalist, the pediatric hospitalist, did think to call the laboratory and ask, what is the test I need to order? Unfortunately, they got bad advice. And they looked in a catalog and found, oh, there's a laboratory in Washington State that'll do a culture for Naegleria fowleri. So they sent the specimen to Washington State. They were still waiting several days later and were holding up the patient's discharge home until they got that result, even though the patient was already getting better and obviously did not have amoebic encephalitis. So there's still ignorance in some of the laboratory and clinical community, physician community, about what is the proper testing. But the CDC Emergency Operations Center can provide advice at any time on diagnosis or management of this condition. So why is it so hard to diagnose PAM in a patient who comes in with meningitis? And so I had to think about it for a little while, and these are some of the possible reasons that I came up with. One is that maybe the clinician just isn't thinking about Naegleria. It is not perhaps going to be foremost in one's mind when a 5-year-old comes in with fever, a stiff neck, and a headache. They're thinking of other organisms like Streptococcus pneumoniae, Neisseria meningitidis, or many different viruses. Another is, even if they're aware of Naegleria as a possible cause of meningitis, not asking about water exposure. More often, what I've seen in the patients admitted to our hospital is that one medical student or resident has asked about water exposure and documented that water exposure in the chart, but then didn't act on it. So if you don't act on it, then you can't make the diagnosis. not asking about the right kinds of water exposure. So when I went to medical school, I learned about Naegleria fowleri. I went to medical school in Tampa, University of South Florida. So being a Florida thing, we did learn about it. But I was taught that you got it from stagnant fresh water, ponds and lakes. I didn't learn anything about hot springs. I didn't learn about running water. I never heard about tap water back then. So there's incomplete education about the epidemiology and transmission of this organism in medical schools. And then another problem is the assumption that the amoeba will be detected by routine testing of spinal fluid, which includes counting the white cells, measuring the glucose and protein, and doing a gram stain and bacterial culture, none of which will detect Naegleria fowleri, as you heard beautifully from Sheila Black. So there is a CDC protocol for PAM therapy, and you heard about most of that from Dr. Liriano. The early diagnosis and treatment is critical, as you've heard many times before. The patient has to be admitted to an intensive care unit with consultations from infectious diseases for general advice on the medications, neurosurgery for the placement of that drain into the brain for installation of amphotericin, and neurology for prophylactic anticonvulsants. Contacting the CDC Emergency Operations Center is very important. Monitoring and managing the cerebral edema is part of that protocol, and then the antibiotics that Dr. Liriano mentioned. And they're summarized in this table that is also available on the CDC website for management of Naegleria fowleri. Those are amphotericin B, given intravenously for 14 days, the amphotericin B that's instilled into the ventricles for 10 days, azithromycin, fluconazole, rifampin, and miltefosine. As you heard, miltefosine is only available by the oral route, so if the patient is not able to swallow, they'll get a nasogastric tube. We can crush up the pills and instill it through the nasogastric tube. Dexamethasone is recommended to minimize the effects of cerebral edema. There's also some data and something that we've included in our protocol, something that our infectious diseases physicians may consider as an option, is that whether to use fluconazole or a similar antifungal called voriconazole, because there's in vitro data to suggest that voriconazole may be more active against Naegleria fowleri than fluconazole. However, it's never been tried in a patient, therefore in a Naegleria fowleri patient. Therefore, fluconazole is still the recommended drug on the CDC website. Regarding miltefosine, that is an antiparasitic drug that's used for leishmaniasis but has activity against Naegleria fowleri. And these are the only Central Florida hospitals that carry it, according to the website of Profounda, the manufacturer of miltefosine. Tampa General Hospital and the James A. VA Medical Center in Tampa, Johns Hopkins All Children's Hospital, Orlando Health, Nemours Children's Hospital in Orlando, and Lakeland Regional Medical Center. And only now 22 hospitals nationwide carry this drug, even though it doesn't cost hospital pharmacies anything to carry it, because it is available on consignment, meaning they can order the drug but they don't have to pay for it until it's actually used. And if the drug's never used before it expires, you send the expired drug back to Profounda and they send you a fresh batch. So we stock it. So it was seen that there was a need for a new management protocol to help remind clinicians to think about PAM in appropriate cases. So a working group was created as a result of the first Amoeba Summit that included representatives from the CDC, Advent Health Orlando, which was Florida Hospital Orlando at the time, Johns Hopkins All Children's Hospital, the Orange County Health Department, University of South Florida, the Jordan Smelsky Foundation, and Profounda. And the goals were to increase public awareness of PAM, prevent PAM, and to provide healthcare provider education to facilitate early diagnosis and early treatment to improve the likelihood of these good outcomes of survival and normal neurologic outcome. So this algorithm was created as part of the protocol. And we're going to go into that, but that's kind of hard to see. So we're going to zoom into the left side of it. And we start on the left side with getting a lumbar puncture for a patient with suspected bacterial meningitis. And if we can get a full 4 milliliters of fluid, that would be ideal for some of the extra testing. So going up to the next box on top, if the CSF is available, one will order the routine studies, the cell count, the glucose and protein, the gram stain and culture. If that's available, we'll go on to the next box to the right. But if, let's go down to the bottom. Let me see if this is a pointer. Yeah, if CSF is not available, then we're recommending, let's say they just didn't get enough, or it was done at another institution prior to the patient being transferred to your institution, then we recommend trying again, and we may need ultrasound guidance by an interventional radiologist to get that, and hopefully we will get that and be able to order the appropriate studies. However, what if you can't? So we've got a little box here for what to do if there's just no CSF available. And this point was mentioned nicely by Dr. Sharon, that if the patient has clinical meningitis or encephalitis and nasal exposure to fresh water within the previous 14 days, we're using a potential 14-day incubation period, consult infectious diseases for possible empiric therapy recommendations. We may not necessarily put in an intraventricular catheter at that point, but we're going to work through trying to figure out how we can confirm that diagnosis. Back up to where CSF is available. Now we're looking at age, and we're going to not do testing in children under 6 months of age, because when reviewing all the United States cases that have been reported since 1962, the youngest patient was 8 months old. In the literature, there is a report of a 1-month-old baby who died of PAM, but in that case, it was a baby in Bangladesh who was being bathed in river water. So we've decided not to routinely test all the 6-month-olds, under 6-month-old patients who present. And if they are 6 months old and we order spinal fluid culture, then the electronic medical record will immediately put up an alert, a window, that will try to remind the clinician to think about asking about water exposure. Now, we decided to use a spinal fluid culture instead of a spinal fluid cell count as the trigger, because we have a large population of children with cancer at our institution, and many of them get frequent lumbar punctures for testing without culture and administration of chemotherapy, and we don't necessarily want to be looking for amoeba in all those patients getting their routine LPs. So that'll help exclude that by doing just with cultures. The alert will say something to the effect of, and the wording can vary from institution to institution, did the patient have recreational exposure to fresh water, lakes, streams, hot springs, pools, or tap water, or perform nasal irrigation with tap water in the 14 days before they came in? And then they have to answer yes, no, or unknown. So we're going to move on to the next slide to see what happens with those responses. So if the response is no recent freshwater exposure, then they'll just have routine studies and empiric antibiotics that Dr. Liriano described. But if the response is yes or unknown, then we want to be able to quickly provide a recommendation or even an automatic order to microbiology to look for the amoeba in spinal fluid. And that should be done at least by a wet mount and the Gimsa Wright stain that Sheila Black described. We also are going to do the third stain, the trichrome stain that's usually used to look for parasites in stool. It has to be a stat evaluation by a tech or a pathologist, so even in the middle of the night, we're hoping that that's going to be evaluated quickly. And then see Appendix A. Appendix A of our document provides instructions on how to do the wet mount and the Gimsa Wright stain. In any hospital that can do a peripheral blood count, they have the ability to do a Gimsa Wright stain. Now, they may not necessarily have the expertise in looking for the amoeba, but I'll get to that in a second. So if amoeba is not seen, then the patient continues on with a routine evaluation, and we stop there with the concern for PAM. But if it is seen, then consult infectious diseases, and at our institution, that's going to be who's calling the CDC. We'll send them to the intensive care unit and order medications. And Appendix B has the guidelines for trying to manage cerebral edema, which includes the total body cooling that Dr. Liriano described, and the medications that I already showed you. We're going to consult neurosurgery to place the intraventricular catheter and consult neurology for the prophylactic anticonvulsants. After developing this protocol, it became immediately evident that we needed to train our laboratory staff. So this is a screenshot for the video that Sheila Black described, and she's actually the main narrator for that video. It is a 1-hour-long video, and it is an excellent training video. And so our microbiology staff watched it first. Then they watched it again when they shared it with other laboratory staff, and especially people who are going to be working on the night shift, because our microbiology lab actually closes around 10 p.m. So we needed people all night long who might be able to look for amoeba in spinal fluid. And the first time our micro staff saw this video, they were so excited about this new thing that they were going to do to possibly help some patients. It's that well done. Here is more of our PAM protocol document. So on the left is Appendix A, and at the top is the description for the wet mount, and at the bottom the description for the right stain. And I got the details for the methodology were very kindly provided by Dr. Cope and Dr. Ali from the CDC. On the right are the management protocols. That includes the details for managing cerebral edema, the drugs, and even one of the footnotes mentions the voriconazole alternative that I had mentioned to y'all earlier. So after we order a spinal fluid culture, this is the alert that comes up to the clinician who just ordered it. So it says primary amoebic meningitis, and I'll just read some of that to you because of the fine print. You have ordered a CSF lumbar puncture culture for a patient over 6 months. It is important to assess for primary amoebic meningoencephalitis. Risk for PAM exists if the patient has had recreational exposure to fresh water, lakes, streams, hot springs, pools, tap water, or performed nasal irrigation with tap water within 14 days before onset of symptoms. If the risk is identified or unknown, please add a microbiology lab order by clicking OK below. If the risk is low, please uncheck the order below. So down there's a little checkbox that's pre-checked, and click the OK button. We provided some education to the ER doctors and the hospitalists and the intensive care doctors about this before it started. We did come up with a problem after it was instituted. Can anybody guess just by looking at that window what the problem is? The problem is it's too wordy. And so some people were not reading it and clicking OK just to get rid of the window. And so a bunch of amoeba tests were starting to be ordered on CSFs in patients in whom we did not need those. For example, children with a ventriculoperitoneal shunt who came in with a fever and a concern for a shunt infection, they would tap the shunt to drain some fluid out, send it off to the lab. They're not particularly concerned about amoeba, but the neurosurgery physician's assistants would see the window, just click OK without even reading it. So the microbiology lab started calling me a lot saying, do we really need to do that on this patient? Because once they start, they're going to be thorough. They're going to do all those, the wet mount and the 2 different stains. And most of them did not need that. However, in the emergency center, we have had a few cases where this alert has already prompted appropriate ordering of the amoeba test in patients who had had recent freshwater exposure. Fortunately, they did not have PAM, but at least now we're doing some testing that we weren't doing a few months before instituting this alert system. So anyway, back to that, we're going to have to change the wording or the structure of it some so that it's maybe bigger print and fewer words so that this mistake is not going to happen as frequently of the over-ordering it. This is the order set. So when one opens the order set for primary amoebic meningoencephalitis, it has some of the same instructions and the ability to order consults for infectious diseases, neurosurgery, neurology. Elevate the head of the bed, placing a nasogastric tube, and it even tells you on the right that that's so that you can administer miltefosine. And then a microbiology message is the order to do the amoeba testing, although that's probably already been done. And then we have down here the medication list. So we have the medications that are already listed, can be checked with the dosing information based on the patient's weight, just to make it as easy as possible. Here we go. On this slide, we have the information about each of the medications, the appropriate doses, and how to prescribe them. So getting this whole process done sounds like it could be kind of easy and quick, but it's not. First, you need a champion. And I happen to be the champion at our institution, but I'm not the first-line person who's going to be seeing these patients. I might be called somewhere down the line. So the champion could be a hospitalist, it could be an intensive care doctor, or it could be an emergency medicine doctor. It could be a laboratorian. You then have to customize the protocol to your hospital, starting with getting information technology input regarding the alert capabilities of your electronic medical record. Then you need to get buy-in from the clinicians in the emergency center, the intensive care unit, the hospitalists, the neurosurgeons who are going to put in that drain. It's good to just let them know that that request may come their way. The quality improvement administrators may also provide some help in monitoring the effectiveness of whatever alert system you put in. They can study it. Then re-reviewing the protocol until the final draft is created. You may think that you've created a really good draft, and then someone else is asked to review it and comes up with a great idea for some obvious problem that you did not see the first time around. And then we have a protocol committee that has to approve any new protocols. Fortunately, I was able to attend and present the protocol in the committee. It passed very quickly, and within a few days, it was posted on our hospital intranet website with all the other approved guidelines, pathways, and protocols for our hospital. Then we also had IT activate the electronic medical alert after that protocol had been posted. We don't want to do the alert before the protocol is available, because then the alert may be more confusing to people, especially if you haven't done any education. And so the education ahead of time is also important. At this time, I'll open it up to any questions, and if later on anybody else has any questions that they just want to send to me by email, my email address is listed there. Any questions about trying to set up this protocol? Yes, in the back. Okay.
How many hospitals besides Advent Health have this alert going on about PAM?
So this particular alert, we have not yet shared it with anybody, and we want to share it with every hospital that wants it. There are some hospitals that have instituted their own alerts. So you heard that Sheila Black described that they have their own internal way of doing it at Advent Health for Children here in Orlando, where the person ordering a CSF cell count has to indicate whether there was a freshwater exposure before that order will go through. I believe, Tim, does Lakeland Regional have an alert? Yes. Dr. Gompf is a pediatric hospitalist at Lakeland Regional Medical Center, and he was able to institute an alert there a couple of years ago, I believe, and so that's been ongoing. And they just created that on their own even before this protocol was finalized. So that would be something else that if you want to be the champion at your hospital or know of someone who might be interested in this protocol, they could just send me an email and I am happy to send it to them. We want to share it with anybody who wants it, especially in Florida and Texas, where most of the cases are diagnosed, but nationwide because we know it's not just limited to the southern states. We've had some ideas of trying to share it in networks of physicians, like emergency medicine physicians, like the Florida College of Emergency Physicians that we just heard about from Dr. Wilson, or pharmacy networks to get them to think about stocking miltefosine in their pharmacies on consignment, or infectious disease, or any other clinician networks that might be able to hear about the availability of the protocol and consider using it. I've offered to write an article about PAM for the newsletter of the Florida chapter of the American Academy of Pediatrics, so hopefully we'll get some information out that way. Any other questions? Thanks for your attention.